free and open to all because expert knowledge should be accessible. The Bateman Horn Center shares this program for educational purposes only. It is not medical advice. Please consult your provider before making any changes to your care. BHC does not endorse or receive compensation from any commercial products or services mentioned. We are, however, raising funds to support development and dissemination of educational resources like the Clinical Care Guide. The views shared belong to the speakers and may not reflect BHC. Because this is a public forum, please avoid sharing personal information to protect your privacy. A recording of this session will be posted to our YouTube channel and shared by email at the end of the month. All participants will remain muted with cameras off to ensure privacy and a timely webinar cadence. Use the Q&A feature to submit a question pertaining to today's session topic. Don't see the Q&A button? Click on More at the bottom of your desktop screen. If you'd like, you can drag the Q&A button to your menu items. Stay connected with the Bateman Horn Center by signing up for the BHC e-News. You will get coffee with the clinician recordings, quarterly newsletters, research updates, new educational resources, and reminders about monthly events. If you are in a position to give, we invite you to help keep these sessions accessible to the community. An optional $5 donation supports BHC education and outreach programs. Together, we're building a culture of informed, respectful care. Thank you for joining us today. The meeting will begin shortly.
Welcome to the January Coffee with a Clinician. I'm Clayton Powers, and I'll be facilitating this series. I'm a doctor of physical therapy specializing in the care of individuals with complex health conditions. I'm also the education liaison at Bateman Horn Center. Before we begin, I want to thank the donors whose support makes our community programs like this possible. And then while I introduce our speakers today, we want to invite you to fill out some questions in a poll for us to better understand your health journey. And we'll show the results of the poll after the presentation. So the poll should pop up on your screen. If you can go ahead and fill that out while I introduce our speakers, that'll be really helpful for us to better understand you and your needs. For this session, Dr. Lily Chu and Dr. Cindy Bateman will present on how long COVID and ME/CFS became diagnoses and how they are defined. Following their presentations, we will discuss how to work with your medical providers to get a diagnosis of ME/CFS or long COVID and answer other questions that participants have written in the Q&A feature. As a reminder, we cannot provide medical advice. Today, I'm really excited to introduce our guests. We have Dr. Lily Chu. She's Vice President of the International Association of Chronic Fatigue Syndrome, Myalgic Encephalomyelitis. She's trained in internal medicine and geriatrics and later focused her work on ME/CFS after being diagnosed with the condition in 2006. Dr. Chu served on National Academy of Medicine committees that developed evidence-based diagnostic criteria for ME/CFS, and more recently, long COVID. She has also advised organizations including the CDC, FDA, NIH, and Cochrane. We also have Dr. Lucinda Bateman, and she's joining us and will speak to us today. She's an internationally recognized researcher, clinician, and educator in the field of ME/CFS and related conditions. She is the founder and chief medical officer of the Bateman Horn Center and has spent more than 2 decades advancing patient-centered care, research, and medical education. Dr. Bateman has advised federal agencies, including the NIH and CDC, and is widely respected for her leadership in expanding clinical understanding and improving outcomes for people living with complex chronic illnesses. Dr. Bateman also served on the IOM/NAM committee with Dr. Chu that came up with the ME/CFS clinical diagnostic criteria. All right, I'll turn the time over to Dr. Lily Chu, followed by Dr. Cindy Bateman, and then after that, we'll show the results of the poll, and we will then have a discussion, a Q&A.
Thank you, Dr. Powers, and good morning, everyone. I'm going to share my slides now. And we can move this a little bit. Let's go to slideshow. For my portion of the talks today, I'm going to concentrate on the 2024 National Academy of Medicine long COVID definition. I'll talk about the committee's rationale, our charge, and our process, then describe the core features and the details of the long COVID definition, talk about how this definition could help with diagnosis, and wrap up with its current state and potential future. If you want to read the definition and our process in full detail, these are links to the documents and a QR code. Specifically, I want to highlight that there's a infographic and a one-page document because these are quick and easy to read. Now, let's go back a few years to 2023. At that time, there were millions of people around the world who were already experiencing ongoing profound symptoms after SARS-CoV infection. There were numerous definitions and descriptions of their condition, but there were significant differences among them. And here in the United States, there was no agreed upon definition. This was a challenging situation for clinical care, research, public health surveillance, and support services. So the Assistant Secretary of Health at the time, as well as ASPR, another federal agency, asked the National Academy of Medicine to convene a group of experts to address this issue. The first phase of our project started in March of 2023, and we were asked to conduct a series of public workshops to examine the current U.S. government working definition for long COVID. We split this phase into two components. The first component, we contracted with a consulting firm called NSPARC, and they helped us create a public online survey for comments, and over 1,000 people participated. They also conducted multiple focus groups with 134 participants. And if you want to read the full engagement report, you can go to the QR code and scroll down and find it. The committee also held 4 public meetings online to gather information, hear testimony, present NSPARC's finding, and discuss the results. This phase was deemed successful. So in, let's see here. The federal government reconvened everyone in October of 2023, and this time they asked us to integrate and synthesize all the information we had gathered to recommend a definition. This is our process. First, we outlined what constitutes a diagnostic definition. Then we conducted a scoping review and examined the primary literature where needed. We heard from yet more public experts and experts in the disease as well as from the general public. And then finally, we met multiple times for deliberations. You might be surprised to learn, as we were, that there are no published standardized guidelines for the development of disease definitions. So the committee went through numerous different diagnostic criteria for other diseases, and we came up with a list of elements that are common to diagnostic definitions, which you can see on this side. For example, a diagnostic criteria might include the cause of the disease. It might include various time elements, such as the onset, clinical features like symptoms, any biomarkers and laboratory criteria, and risk factors. However, no diagnostic criteria needs to include every single element to be effective. We also came up with a list of 7 factors to gauge the definition by to help us guide its creation. And these were precision, feasibility, acceptability, accessibility. We also wanted to balance benefits and harms of diagnosis and avoid unintended consequences. The definition was created to be intentionally inclusive. We recognize that people with long COVID could present in a variety of ways. We also wanted a definition that could accommodate evolving scientific discoveries and different uses. And finally, we wanted to address the impact of social determinants of health. Ultimately, the patient's treating clinician is best poised to strike the right balance between avoiding a false positive and a false negative classification. We also included 3 relatively new terms throughout the report. We decided to name the condition long COVID because it was a simple, familiar, and descriptive term. And these traits are consistent with World Health Organization guidelines for naming new diseases. As many of you also know, this was the term that was originally proposed by patients. We also included the term infection-associated chronic condition. We wanted to recognize that long COVID was not an entirely new entity and that it shared symptoms and features with already known conditions like ME/CFS, post-treatment Lyme disease, Q fever syndrome. All of these conditions are precipitated or triggered by microbes, and so discoveries in treatment, pathophysiology, diagnosis could benefit all of them. This is the core long COVID definition. Long COVID is an infection-associated chronic condition that occurs after SARS-CoV-2 infection. It is present for at least 3 months as a continuous relapsing and remitting or progressive disease state that affects one or more organ systems. And this was published in June of 2024. Now I'm going to go on to the next graphic, which is very complicated, but I'm going to walk you through it. So this is the infographic, and it's found in all of the National Academy of Medicine publications, and it's also was published in the Journal of General Internal Medicine last year. Long COVID starts with an acute SARS-CoV-2 infection, which may or may not be picked up by testing, especially during the early portion of the pandemic, as all of you might remember. The acute infection can be asymptomatic, mild, moderate, or severe. We listed 15 common symptoms among that we saw in patients, and these again can vary in their severity. I want to make it clear that you don't have to have all these symptoms to be diagnosed with long COVID, but if you have several together, then that might tip you towards the long COVID diagnosis. We also put in a note that there are over 200 other symptoms, so this is a non-exhaustive list. These symptoms can start while people are in the acute phase. It can start immediately after, or it can even be delayed in onset. So weeks or months after the acute infection. We listed a variety of diagnosable conditions that could be worsened by long COVID or could be newly developed. Besides cardiac, pulmonary, and neurologic conditions, we specifically named postural orthostatic tachycardia syndrome and other forms of dysautonomia, mast cell activation syndrome, ME/CFS, and a number of autoimmune conditions. We also pointed out that long COVID can affect anyone, regardless of prior health, age, sex, gender, that some people, they do recover within a few months, but other people can be affected for years or indefinitely. That the diagnosis can be made on clinical grounds. Currently, there is no test for long COVID, and there wasn't any back when we were creating this definition either. And that long COVID can affect function significantly. The next 2 slides have a lot of text. You can read it at your leisure because it just recaps what I just said. So how is this definition different or useful? We use intentional terminology, which I just described. We provide an explicit but non-exhaustive list of common symptoms, which some of the previous definitions did not, and that made it very hard for clinicians to diagnose long COVID. We require a duration of at least 3 months, but we don't restrict when long COVID can begin. We include, as I mentioned, delayed onset because the public told us in some cases they recovered from the acute infection, but then they were fine for several months and then their long COVID symptoms started. And we were vindicated by this recent paper last year, which showed that 6% of people infected by SARS-CoV didn't develop the symptoms of long COVID until 12 plus months after acute infection. Our definition also recognizes different course patterns, so you don't have to have symptoms continuously. They can be intermittent. They can also be worsening, and your clinician doesn't have to think, oh, this is another condition, although they should do a differential to make sure there isn't anything else. We also established that long COVID is not a diagnosis of exclusion. Patients told us that their doctor might diagnose them with POTS or diagnose them with lupus occurring on the heels of SARS-CoV infection, and they were told that they couldn't have long COVID, even if their symptoms weren't explained by their current diagnoses. Secondly, if someone is already diagnosed with long COVID, it's a good idea for their clinician to look at that list of coexisting conditions, because many of those conditions can be diagnosed with current tests and there are effective treatments for them. And finally, if someone has, for example, lupus triggered by SARS-CoV, if there are future treatments for long COVID, those treatments could really benefit them beyond the medications for lupus, for example. Currently, the definition has been adopted across federal agencies, including the CDC and NIH. However, I think the monitoring of its use has been hampered by changes at the federal level. For example, some of you might remember that the Secretary's Advisory Committee on Long COVID was dissolved in February of 2025. Now, the definition has a year in it, 2024, because the committee anticipates that it will change. It will be refined, hopefully, by future new discoveries, such as a definitive test for long COVID. Consequently, we suggest that it be revisited in 3 years, so that would be around 2028, or whenever significant research findings emerge, so whichever timing is earlier. Now, I went through this very fast, so feel free to ask me questions during the Q&A period. Thank you.
All right. Thank you so much. All right, Dr. Bateman.
All right, can you hear me?
Yes.
All right. It's great to be able to come here today, and especially with Lily, because I just think Lily's been an amazing person behind the scenes much of the time for the last couple of decades. She's pretty amazing. So I'm going to, switch gears and talk a little bit about the case definitions for ME/CFS and why we have what we have. I also would like to just tell you that the goals of my presentation today are talk about the 2015 ME/CFS IOM and NAM clinical diagnostic criteria. I'll talk a little bit about the Canadian consensus criteria and the international consensus criteria, and a little bit about why Fukuda fell out of favor. I want you to understand the difference between research criteria and clinical criteria. And then really our whole point of all of this is informing clinical providers about diagnosing ME/CFS and long COVID. So we can't go through the whole background of ME/CFS, but just briefly, the term chronic fatigue syndrome first appeared in a publication in 1988. And it was done after a study of post-infection outbreaks. And they really wanted to replace the term chronic Epstein-Barr virus, which was becoming widely used. And they published a research case definition to try to study it. In 1994, they revised the research case definition because that one wasn't working in all situations. And they created the Fukuda criteria. And these were research criteria as well. That's a long time ago, right? Then, providers who were seeing patients got together and published, they got together in Canada and published what we know as the Canadian consensus criteria in 2003. And this was really a very descriptive, these were very descriptive clinical criteria about the way patients were presenting. And it was probably the first time that post-exertional malaise was required. It was in the Fukuda criteria in 1994, but it was one of several features, and it wasn't a required feature. So there are many criteria, and we could spend 2 hours probably talking about criteria. But if you want to learn about these criteria, you can read the whole NAM, National Academy of Medicine report on MECFS, which I love. We authored it. Or honestly, I go to Wikipedia all the time because it's done by volunteers, and they have a lot of great sections. I'm sorry, Mepedia. And they have a lot of great sections explaining each of the criteria. So a little background on the IOM report. It was called the Institute of Medicine back then. And in 2013, the Department of Health and Human Services issued a contract, and it was funded by all those different agencies. And this contract was accepted by the Institute of Medicine, and it was specifically to review the MECFS literature and propose clinical diagnostic criteria. And the purpose of the IOM report was to facilitate more timely diagnosis and care. It was really aimed at clinicians to enhance understanding among healthcare providers and the public. It was more than a year of a committee that was made up of, a couple of dozen people with great expertise in the area or related areas. And this was published in February of 2015. And there were some documents produced. One was called the Key Facts, which was short. One was called the MECFS Clinician's Guide, specifically for clinicians, that was medium in length. And then there's the full 280-page report called Beyond Myalgic Encephalomyelitis Chronic Fatigue Syndrome, Redefining an Illness. That's a typo there. And if you want to go to that link, you can access, this is my favorite link to look at the report because there's an index and you can pick and choose what you want to read in the report. But the purpose of this literature review, just to reiterate, was to improve clinical diagnosis. And it was especially directed at primary care providers in the US who were woefully unaware of MECFS. And these, in order to make them visible to this medical community, they were evidence-based, which is necessary, highly respected process at the National Academy of Medicine, Institute of Medicine, and it was published in a format that was accessible to clinicians. And these were critical aspects of the plan. Recommendations from published research in the 1980s through mid-2014 were reviewed, and the core criteria were based on characteristics of well-defined MECFS patients who were seeing MECFS specialists. I will say that they're probably more moderately ill patients because severely ill tend to be less represented in all the literature. And in the IOM NAM criteria, the existing MECFS case definitions were really reviewed and summarized. So here are the MECFS clinical diagnostic criteria and I'll just call it the NAM. So first of all, the core criteria below are required for diagnosis, the cluster of them, not just one, not just two. And the symptoms should be moderate to severe and present 50% of the time for those with the asterisks. And that's based on the literature that separated mild symptoms in the general public that occur to everybody to people who were diagnosed with this illness that have more severe, more pervasive, and more interacting symptoms. So the first one is impairment of function accompanied by fatigue. And we purposely demoted the term fatigue and put the first criteria as impaired function, and put fatigue kind of in the background. The second is what happens if you exceed that function, which is post-exertional malaise or illness relapse. And then unrefreshing sleep is sort of a grab bag of sleep abnormalities. And then at least one of the following, either cognitive impairment or orthostatic intolerance. And in the report, it goes in depth into autonomic nervous system dysregulation, not just orthostatic intolerance. And at least one of the following came because the literature was stronger for cognitive impairment in adults, and the literature was stronger for orthostatic intolerance in the pediatric population. So in addition to these core criteria, there are common but not required features of illness, which I'll review for you here. And those are chronic pain conditions, immune and inflammatory manifestations, infection manifestations, and neuroendocrine manifestations. And I want to mention that, honestly, this literature review stopped in mid-2014, And in the latter part of 2014, there were several conferences that highlighted really important advances in central and peripheral neurologic findings in ME/CFS. So they aren't as included in the report. And then clinicians were encouraged to diagnose ME/CFS definitively after 6 months of supportive care and diagnostic investigations, but a working or provisional diagnosis can be made anytime in the process, and patients shouldn't wait for care and a diagnosis. And during that time, supportive care and management should be provided. And this was a bone of contention. No exclusionary criteria are detailed, but that's because this is directed at clinician audiences. And it's expected that a differential diagnosis and appropriate workup of symptoms and treatment should be ongoing during this process. And doctors were also encouraged in this report to diagnose and treat all other identifiable illnesses, including supportive care, observation, and reduction of risk factors. So let me take a minute and emphasize the difference between a clinical and research case definition. So the first two that we talked about in 1988 and 1994 were research case definitions. And those definitions are narrow by design and used to identify subjects for research that clearly have the diagnosis, but ideally their presentation is not complicated by age or medical or mental health conditions that might confound the research outcomes. But you might be able to see already that's not a great diagnosis to use in diagnosing people in the community. So clinical case definitions or clinical diagnostic criteria are used to identify people with the diagnosis, especially when there aren't objective markers. They're very inclusive, not exclusive. And, I like to say, can someone with ME/CFS still get diabetes or sleep apnea or, develop obesity or have a secondary mental health problem? Of course they can. So they aren't excluded from a diagnosis. It just becomes more complicated, right, to tease apart the things going on with them. And they require some medical attention. So I just want to very briefly compare the Canadian consensus criteria that were published in 2003. And these were the first criteria that used the term ME/CFS instead of chronic fatigue syndrome, at least in those that I presented here. But what I want to show you is all of the things in red were included in the 2015 National Academy of Medicine core criteria. So substantial reduction in activity, post-exertional malaise, disordered sleep, neurologic and cognitive manifestations. The only one that wasn't core, but was listed in common symptoms were pain. And really that came from data that showed there are people in stages of this illness that don't have a lot of pain syndromes. You can create pain for sure, just like ordinary people can. And this can be debated. And of course, among individuals, it's incredibly different, right? And then the Canadian consensus criteria lists autonomic, neuroendocrine, and immune manifestations. And the autonomic manifestations are included as core criteria in the IOM criteria. And then neuroendocrine and immune are listed in the common symptoms to look for. So there's a lot of similarities between the way the NAM criteria were devised and what they kind of modeled after the Canadian consensus criteria. I would say that the Canadian consensus criteria describe, if you include them all, a more ill patient with multisystem disease. But as Lily stated, you don't necessarily have to have every symptom in a case definition. So the International Consensus Criteria published in 2011, and I was actually an author on this publication because of the work of Alan Light looking at biomarkers. And really, there were only a couple of things really different. These criteria were published by a similar group by consensus. They dropped the term CFS, so it was just ME. And they spent a lot more time discussing, instead of using the term post-exertional malaise or PEM, they used the term PENI, post-exertional neuroimmune exhaustion, and then they detailed the aspects of PENI. And this is really informative and educational. So all of these criteria offer some benefits. But remember, the IOM or the NAM criteria, the clinical diagnostic criteria of 2015, are aimed at medical providers who don't know how to make a diagnosis, right? So those core criteria to recognize are very important. Before closing, I want to show you a couple of things. So this is a table from the US MECFS Clinician Coalition paper that was published in the Mayo Clinic Proceedings called MECFS Essentials of Diagnosis and Management in 2021. And these common comorbidities are listed in the paper. And what's important about this is, we need to tease apart those really global presenting symptoms in the case definitions. And this is done in doctor talk. So what I mean by that is every medical doctor, whether they understand MECFS or not, can look at this table and recognize these conditions in the way they're trained in medicine. They may not be good at all of them, but they would recognize that these are valid conditions. And this helps clinical providers recognize and start to tease apart what they can do in their patient instead of just saying, oh, there's no treatments, right? Well, there are lots of supportive treatments, and sometimes the way to address them is one by one based on these presentations. I also wanted to show you a few things from the BHC Clinical Care Guide, and we're using Chapter 2 as the focus of our presentations today. In the Clinical Care Guide, after listing the IOM or NAM criteria, they talk about additional symptoms supporting diagnosis, and you can see they broadened it. We've broadened it a little bit from what was in the IOM report, adding in, talking about the immune system, more focused on neurologic symptom. And autonomic and endocrine are really grouped here for a reason, because it's kind of difficult to tell the difference between symptoms caused by autonomic or neuroendocrine systems. And then emphasis on pain and gastrointestinal and gastrourinary symptoms. And here's the chapter guide from Chapter 2 in the Clinical Care Guide. And you can see that after the introductory statements, there are chapters on those 5 core presenting symptoms of MECFS in the IOM criteria. So assessing impaired function, post-exertional malaise, sleep, cognition, and orthostatic intolerance. And then after that, the chapters go into more detail in these comorbid conditions, focusing on comorbid conditions that physicians may not be as familiar with, diagnosing and then addressing treatment for. So I strongly recommend that people read through, get a hold of this clinical care guide. And of course, our whole goal of the clinical care guide, just like the IOM NAM 2015 clinical diagnostic criteria, is to increase recognition and diagnosis. So I've put a couple of links here that we can put in there. One is that link to the full National Academy of Medicine report and clinical diagnostic criteria of MECFS, and then that US Clinician Coalition expert paper in the Mayo Clinic Proceedings. These are really good references that you can use and you can also send your clinician to. So thank you for the time, and I look forward to addressing additional questions.
Thank you, Dr. Chu and Dr. Bateman. We're sorry for ending the poll so quickly. We will relaunch the poll so that everyone has a chance to fill it out, and so that we can share the results when we share the presentation slides. So go ahead and work on the poll. And then for those, I did have a question for the audience and anyone attending. I would like, you can comment in the chat. What has been your experience trying to get a diagnosis of MECFS from healthcare providers? So once you're finished with the poll, go ahead and comment in the chat. And then I wanted to start with Dr. Chu. Who would you say, which type of healthcare provider can diagnose long COVID or MECFS?
I think that any clinician with medical training and experience can diagnose it. So whether that is a physician, nurse practitioner, physical therapist like yourself, I think anyone can diagnose it. And the definitions that we just went through were created in mind, as Cindy alluded to make it easy and accessible to primary care clinicians. Now, there are 2 circumstances where I think a specific person might have to make the diagnosis. The first is when insurance coverage is involved. So for example, if you need to get a tilt table test, your insurance company might require that you have a cardiologist make that diagnosis and order a test. And the second situation might be when you're applying for disability benefits. And in some cases, they might put more weight on whether your primary care clinician makes the diagnosis. And in other cases, they might put more weight on the specialist making the diagnosis.
That's super helpful. Do you suggest, at what point would you suggest someone finding a different doctor if they're not receiving the care that they feel is appropriate?
So that is a complicated question, and I think every person will need to decide for themselves what their relationship is like with their clinicians. In terms of appropriateness, I was thinking about how do you break this down? So obviously, if you have a clinician who dismisses everything that you're saying to them, if they're being disrespectful, then that is clearly not appropriate, even outside, MECFS, and one should consider changing clinicians. However, I think patients should also think a little bit about their expectations. So I've had patients send me emails rarely and ask for my opinion. And I say that if you go to a clinician expecting a cure for MECFS, that is relatively unrealistic because we don't have great disease modifying treatments right now. And secondly, if you go in thinking I'm annoyed at this clinician or angry because they won't order a certain test or treatment, that can be a complicated situation as well, because in some cases, the clinician has good reasons why they don't want to order the test or the treatment. For example, the evidence might not be enough, the evidence base from a scientific point of view, or they don't feel familiar. For example, there were trials of rituximab in MECFS, which I thought were fascinating to read. But if I was a practitioner, just a general internist back then, I would not feel comfortable ordering rituximab because I just don't have much experience with it.
Yeah, I see a lot of that hesitancy from healthcare providers to diagnose MECFS or even to provide some treatments, because often the evidence base for some of the treatments or their familiarity with those treatments or ME are not there. So, Dr. Bateman, why do you think healthcare providers are hesitant to diagnose MECFS?
Again, that's a complicated question. I think that's changing. I feel that the Institute of Medicine report in 2015 was very pivotal in getting information out there, because it's slowly changed from "I don't believe that's real" to "I believe it, but I have no idea what to do about it."
Yeah.
Right? And a lot of clinicians just don't feel armed and ready, right? They aren't, we haven't been able to really get good physician education around these illnesses, in part because physician education requires teaching only from a strong evidence base. So they're not allowed in medical schools and other places to treat things that haven't been proven already, which is really problematic. We don't have to argue that. I mean, so that's why we focused our efforts hugely on empowering patients and their clinicians with information that doesn't have to come through those official channels. But it's a lot harder to crack the nut, right? It's a lot harder to get yourself in the door. I mean, I've been working on this my whole career, trying to communicate with other physicians. That was the first thing I started doing when I opened my fatigue consultation practice in 2000. The year 2000, and my goal was to raise awareness among the medical community about these illnesses. So it's challenging.
Yeah, definitely.
I
And one
wanted
of the
to add to
questions,
what
oh, go ahead.
Cindy just said. Another challenge and why physicians and clinicians were hesitant to diagnose is they might have thought that it didn't make a difference for patients. And yet we know first from the literature that it's really reassuring to patients, even if they're diagnosed with a disease that we don't have great treatments for, to have an idea of what they have. They can at least know, well, my chances of dying from it, are not high compared to other diseases. And there's literature showing that 70% of clinicians thought it was wasteful to give a diagnosis, this is a few years ago, of ME/CFS, but 90% of patients thought it was very useful. And then a second piece of it was that we do have, and this is Bateman Horne Center's one of their missions, to educate clinicians that there are things they can do. So even if it doesn't cure the disease, teaching patients about pacing, for instance, or telling them that you can try compression stockings, electrolyte water mixtures to help your POTS can make a difference. There are things you can do.
Thank you.
Can I add a
thank you
thought
for
to that?
clarity. Yep.
One of the things that's been really effective and improved the care of ME/CFS clinicians, right, is understanding comorbidities. And there's been a big, that's really been evolving in the last decade. And that is, oh, look at these commonalities, right? And we can tackle mast cell activation. We really ought to understand the dysautonomia more and being able to hone in on these things. And so we're trying to pass that on to clinicians. And I would say, back up what Lily said, you don't want to have someone who doesn't respect you, right, and who won't listen to you. But there are many, many good providers out there who are willing to care for you, who may not feel confident yet. But one of the ways is to look at those tables and take to them comorbidities you think might be going on in your illness, and you can start with that, right? And say, could I have irritable bowel syndrome, or could I have POTS, or some of the things. And that is the way you chip away, right, and work on a relationship with your clinicians. I want to say something just maybe obvious, but I want everyone to know we completely get how horrible your experience is with clinicians out there. There's some good ones, but we know too, because we try to collaborate with those providers and have to teach them. So yeah, it's a really horrible situation. Our field needs two big things: research advances, but it also needs diagnosis and access to medical care. And they're equally important side by side.
Absolutely. We run into that a lot when working with other clinicians and trying to educate them. A lot of this pushback or questioning. So I wanted to hit on a few of the questions from the Q&A. One quick one is, can patients self-diagnose ME/CFS based on the case definition and their lived experience? And would that be acceptable, or do they have to have the medical provider agree with that diagnosis?
Can I take that first?
Yes.
The answer is yes and no. Okay. I think you can totally see if you meet the criteria, and you can know if you niche in there. What you're missing is the differential diagnosis, right? And you don't want to miss another important illness. Either that's masquerading as ME/CFS, or that is confounding or comorbid with ME/CFS. Like cancer, for example, right? There are things, I mean, the list is so long, that's why you need doctors. And so sometimes you just take the mind of your doctor off the ME/CFS and let them work on working up the symptoms and the aspects. I tell people when they go to the ER, I don't do this quite as much, but don't start by saying you have ME/CFS. Whatever you're in there for, talk to them about your symptoms and let them think like a doctor first. Right, and do the workup that's needed, and that's what's really important. A step beyond self-diagnosis.
Yeah, I wanted to add to that. Clayton, you had a very good question about what if you can't find a provider to diagnose you, or if you're in an area like a rural area or even a metro area where there isn't anyone available. And there are, if you go through the materials on the Bateman Horne Center, there are suggestions for treatments that people can try out themselves that have very little downside. So for example, pacing has very little downside. If you don't have ME/CFS, then you just do however much activity you want to do without any symptoms, and that's fine. And also things like trying compression stockings for POTS or increasing your fluid intake is also relatively benign. So there are things that you can try even as you're waiting for a diagnosis potentially.
You can also, when you go into your provider, say, I know you don't feel comfortable with the diagnosis of ME/CFS, but can you help me do a workup of my fatigue? Right? Or can you help me make sure that this pain in my abdomen, that we understand that serious things have been excluded. So if you could talk to them on the level they understand, right, that builds those bonds and lets them do that for you. That's what you need them for.
This also reminds me
Absolutely.
that should you try things like pacing um, or more benign measures and you do feel better, to tell your physician about it. Because physicians are always told you should ask about they always ask patients, what makes your symptoms worse and what makes it better? And if you tell them these steps, which you found from reading a guide on ME/CFS or long COVID, made you feel better, then that might help them consider the diagnosis more.
Great, thank you. Dr. Chu, I wanted to ask another question from the Q&A is basically why have a separate diagnosis of long COVID ME/CFS instead of just calling it ME/CFS? What's the importance of having it, the diagnosis of long COVID?
So in my mind, the two diagnoses are related, but they're different diagnoses. 50% of long COVID patients fit the National Academy of Medicine ME/CFS criteria that Dr. Bateman went through, but another 50% do not. There are people who have significant heart, lung, neurologic complications related to their SARS-CoV infection, but they don't have unrefreshing sleep. They don't have PEM. So having long COVID does not mean that you necessarily are affected by ME/CFS. On the ME/CFS side, that those diagnosable conditions, again, we say in there that they can be precipitated by SARS-CoV, but they can also be exacerbated. So if you have ME/CFS pre-COVID and then it became worse after COVID, right now we don't have the resolution of testing to say, okay, these symptoms are from ME/CFS and these are from long COVID. But the reason why it's important to keep that in the back of one's mind is if there are treatments for long COVID in the future, perhaps people with ME/CFS exacerbated by long COVID could try it and it might relieve some of their symptoms.
Thank you for clarifying that.
I'd also like to point out that probably many other infectious causes can lead to chronic illness that doesn't rise to meet the criteria for ME/CFS. So, and think about long COVID as, well, if you have altered sense of smell, right, from COVID, that's long COVID, but that's not ME/CFS. So it really has to do, and remember that the ME/CFS criteria are merely a description of your presentation. It doesn't dictate how you got there, what infection or what process took you there. So I kind of have a habit, it probably doesn't matter, right? But I have a habit of, if I know the onset, like I'll say post EBV ME/CFS or post CMV ME/CFS or post-COVID ME/CFS, just to remind me that those symptoms seem to occur after that infection. But it doesn't change my management for the most part, except it leaves the door open to addressing the specifics of that virus, which is, I think, what Dr. Chu is referring to, right? If we get some treatments that are very effective for long COVID that are aimed at the virus, they may or may not help other ME/CFS patients. But if those treatments are aimed at the comorbid conditions, they may apply not only to post-COVID ME/CFS, but to other people with ME/CFS who share those comorbid conditions.
Excellent point. For those attending, go ahead and comment in the chat if you did finally get a diagnosis of ME/CFS from a healthcare provider. What changed that helped you to get that diagnosis? And we will record all the comments and things so that we can really understand how to best help and also to understand your situations. Dr. Chu, when we last met, one of the things that you brought up that I felt is huge is, what is the role of listening and validating in the healing process?
Yes, and when I thought about that question further, I thought really that this would be a great question for if we were addressing clinicians, because really they need to learn about what they can do, even when we don't have great treatments for a condition. So I was telling you in our prior prep visit that my paternal side of my family has a background in the traditional Chinese medicine. And so my mother told me that besides what the doctor can do for you in terms of medications or procedures, a huge piece of it is the relationship that you have with them. And the best doctors don't just treat your symptoms, they make you feel better just by being themselves when you visit them, and you feel better. And my example was I had a great primary care clinician who's since retired. And every time I went in to see her, she would ask me, besides, how are your symptoms going? What are you taking right now? Are you able to take care of yourself? Are you financially stable? And that's because, as you mentioned earlier, I have ME/CFS myself, and I always felt better after seeing her, even if I knew there wasn't anything new that she could offer me. We don't talk about it as much in medicine, but in the mental health professional field, I think they call this the therapeutic alliance, the relationship that you have with your psychologist or psychiatrist or mental health professional that really helps with treatment, even besides medicines.
Absolutely. I feel like that is underutilized or underrecognized in healthcare, the value of listening and validating when someone comes in. I so often hear patients describe how their providers don't listen, that they don't have enough time with their provider to explain their needs and what's going on. And so, such an area that needs to improve in healthcare. One of the questions we
I want
have.
to add a
Oh,
little
yeah,
bit
go
to
ahead.
that. So in my slides at the end, if people receive the slides, they can look at it. I list some tips for working with your healthcare professional to get a diagnosis or get the treatment that you need. And it occurred to me that people in the audience probably have had experiences where they had to persuade someone to change their mind or to do things differently. And so think about the principles that you used or the techniques you use to persuade someone in other situations and consider applying it to your medical visit. And in particular, I referenced Robert Cialdini's book, Influence, which talks about 6 principles of persuasion. And he is a longtime professor who studies the art of persuasion. So he has free materials online that people can look at. So one technique, for example, would be authority, which is showing people articles from the New England Journal of Medicine, from the National Academy of Medicine. Another technique is social proof. So if you have one clinician in your team of clinicians who thinks, oh, you have ME/CFS, or tells other clinicians, I think, consider this diagnosis, that might also influence them if someone else thinks it. And third is consider complimenting people or bringing something positive to the table. Tell the clinician, oh, you helped me so much in this past situation, and I would really, I think you could help me with this situation. Put something positive in the appointment.
I love that. Yeah, that would definitely help. Dr. Bateman?
I just want to share a quick anecdote of something that happened to me yesterday that's positive. And that is, I have a very complicated patient, and she started seeing a cardiologist for her POTS. And of course, the cardiologist is just kind of they aren't thinking multiple systems and, all the perfusion, all the things we do. And he put her on a medication for her POTS. And then I met with her, and there was some benefits and some downsides. And then I thought of another intervention we could do. And I called him and I said, I just want to run this by you. You're her cardiologist, but here are my thoughts on this medicine. I got all done. And he goes, oh, and I said, and thank you for helping, right? This is example of thanking, right? And I just want to make sure you're okay with this. And he said, I just want you to know you're an 8 out of 10 on this, and I'm like a 2 out of 10 right now in my knowledge. So I'm happy to work with you. And I thought, wow, that hasn't happened to me for a long time. So here's someone open-minded, willing to learn, maybe thinking a little outside the box, and together, right, we can educate him and he can help our patients. So that made me happy yesterday.
I also want to tell people that, like Dr. Bateman said at the beginning, we are very aware that people have had negative experiences with clinicians, but especially for people who've been sick for a while, like me, to go into appointments with a somewhat neutral stance because the world is changing. And just to give you an idea of that, I help my family members with medical issues, and it's often doctors will ask me, "Oh, where do you practice?" And I tell them I don't practice anymore because of ME/CFS. And then they ask me, more about it. And I've had people, like one cardiologist spent 10 minutes on the phone with me, quizzing me about ME/CFS. I very politely, he wanted to learn more. And then I had another sleep doctor take 15 minutes and just ask me, can I just have some time with you and learn about this? And I said, okay. So I think people are they're changing. It's slow, but it's getting there. And there are clinicians out there who who have family members who themselves are sick. So they're much more open to these diagnoses.
Yeah, I would agree with that. The hope is on the horizon. There is change happening as we educate more healthcare providers. COVID really opened up a lot of people's eyes to ME/CFS, and there's more research being done in this area. And so, Dr. Bateman, I had one more question from the Q&A, and that is, why is unrefreshing sleep a required criteria for the diagnosis? I would somewhat change that and say, what are some of the, how did you come up with some of those criteria as a committee?
Well, I'll say that unrefreshing or disturbed sleep is an integral part of the diagnosis. It's required because it's ever present in some degree, and it's in the fibromyalgia criteria, it's in all the ME/CFS criteria, and it's in the long COVID criteria. I'm going to give a talk on sleep to doctors in a short time, and so I've been researching it. But there's not one kind of problem with sleep. So there can be all kinds, including being too sleepy all day and including not sleeping at night and everything in between that lead to unrefreshing sleep. And essentially it means you should feel refreshed after sleep, but most people wake up feeling not that refreshed after sleep. So the other reason I think it's important is my years as a clinician, and that is the better we can help people establish restorative sleep in a healthy way, the better they feel during the day. So it's a really important self-management tool with a little help from prescribers at times, but I see it as a really key component to moving toward a more stable symptoms and improved symptoms.
Great, thank you. Dr. Chu, one more question. If someone lives in a rural area where they don't have access to specialists and the care they need, what would you suggest for them? What are their options?
So earlier I had mentioned, first of all, looking at the materials on the Bateman Horne Center or other websites and looking at steps that you can take personally. For example, Cindy just talked about sleep. So another technique might be if you're able to schedule the times when to modify your sleep schedule to fit what you need. So if you're able to sleep later in the night, like I know some ME/CFS patients who don't go to sleep until 1 or 2 a.m., then do that. So there are things you can definitely do that can help you that you don't need a clinician for. Um, in the rural area, my experience is that sometimes you can obtain a virtual consult. It's even more now. I was trained in a rural area for 6 weeks 20 years ago, and they used the telephone back then. And now it's even better because we have video conferencing. So in some cases, you might be able to get access to a clinician through virtual means. But you have to look into things like what are the rules regarding telemedicine right now? Can you see a doctor outside your state? Will your insurance cover it? And that will really vary from state to state and from situation to situation.
Thank you. That's helpful to know, especially for those in rural areas, how to handle some of that. Well, we're out of time. Thank you all for joining us. We'll share the results of the polls in the email we send out. We hope to see you again for our next session on Wednesday, February 11th at 10 a.m. Mountain Time, where We'll cover common comorbid conditions that occur with ME/CFS and long COVID. So we'll send a recording or an email with the recording and associated resources, and then please complete the brief survey that will pop up on your screen. We look forward to seeing you next month.
And I want to thank everyone for their comments. I'm trying to read them, but it's difficult doing two things at once, so I will read them later.
Yes,
Take care
thank
of
you all.
yourselves. Don't give up, okay?